she's back.
No making fun of me.
No, we were just saying we wanted to all log off and just not be.
No, you can't. You guys have to stay. Mine was a legitimate mistake. I think I have control now. Okay. Hold on just a sec. I'll put it back up. I'll share the screen and I don't know what's happening with this day, but it's just a strange day for some reason. Where is my Kahoot screen? The pin is 1766348. This is what I want. I want this screen, share screen. There it is. Share. We need to be recording. We are recording finally. Ay, ay, ay. Okay. I think we're good. So we got 28 people. We should have at least maybe 1 or 2 more, but if you don't want to play, you don't have to, but it's more fun if you do. Okay, so we're going to start here. I'm going to press start. There's 50 questions. It's all important material. Not necessarily everything that's going to be on the exam is on this Kahoot. So you still want to do all your regular things that you always do, but this is going to be a very helpful study guide. And then, but remember that things can be worded in different ways too. So you have to really know the material, not just know the way something might be questioned, because it might be questioned differently in another scenario. So you really want to make sure you know the material. But this should be a good study guide. So here we go. Crying inside. Here we go. An individual with Alzheimer's disease has too much acetylcholine, too little acetylcholine, loss of glutamate. Good. Too little acetylcholine. So I know it's just, and then they remember they might have too much glutamate. Like there seems to be excessive glutamate and too little acetylcholine. And acetylcholine has to do with memory and learning, is how it manifests itself in that situation anyways. Okay. The NMDA receptor antagonist slows the progression of Alzheimer's. I've just blocked my question by, I know it's a lot of reading, should have made these 30 seconds. Blocks the effects of glutamate. So the NMDA receptor antagonist, so it's a blocker, and it's going to try and block that increased glutamate that appears to be hanging out. Because remember, glutamate is excitatory neurotoxin, and it's like it kills the neurons. So we want to try and block that too much glutamate. When you hear the term plaques and tangles, what disease comes to mind? Plaques and tangles. Alzheimer's. So remember that little video where they were zooming in on the neurons, and then you could see the plaques and tangles that start to form in the around the neurons. There's a little video that it's either embedded in and it shows a really nice visual of it. But when you hear those two terms, plaques and tangles, think of Alzheimer's, because that's what it's like. That's choking out the neurons in the and building up the plaques in the brain, and then it cuts off blood supply and the brain shrinks. It's almost like you can think of it as like this invasive thing taking over. So kind of add a visual aspect, plaques and tangles, Alzheimer's disease. An inhibitory neurotransmitter involved in skeletal muscle movement is, So which neurotransmitter is important in skeletal muscle movement? Dopamine. So dopamine is, if it's going to be in less amount for someone with Parkinson's. And remember, Parkinson's, there's that shuffle, that kind of shuffling gait. They don't have so much, there's tremors, more like the shaking. So they're having trouble moving around, and there's a limited amount of dopamine for someone with Parkinson's. A general seizure includes both absence and tonic-clonic seizure. True or false? True. It's about split 50-50 there, pretty close. But general just kind of means it's in the whole area, like the whole brain, general. So you can have an absence, which is also called petit mal, or you can have the tonic-clonic, which is also used to be called the grand mal. So you can have them both be general seizures. So it can apply to both. Drug therapy for Alzheimer's includes the following except, so 3 of these drugs are used in Alzheimer's treatment. 1 of them is not. Which one is not used in Alzheimer's treatment? Good, levodopa. And remember, they always put levodopa and carbidopa together because it helps it get through the blood-brain barrier or something. But that's the only one. That's for Parkinson's disease, levodopa. For treatment of seizure, what should be increased? So what neurotransmitter or one of these other substances, what would you want to increase to help with seizures, help control seizures? GABA, good. So all the other ones, sodium, calcium, and glutamate, the other medications tend to lower sodium, calcium, and glutamate. And then you want to increase GABA because that has that kind of almost relaxing, kind of evening out of the brain. And it also can be used in anti-anxiety medication too, but it works for seizures too. A patient diagnosed with schizophrenia could be prescribed which medication? So which of these, I mean, I suppose that's maybe not the best question, but which one would you specifically see maybe on a med history of someone with schizophrenia, for schizophrenia? Haldol is the right, and I know that might have been a hard one because maybe someone with schizophrenia is also taking a sleep aid. So it's kind of a tricky question, but specifically Haldol is prescribed for individuals with schizophrenia, or can be prescribed. Okay. A seizure that lasts less than 20 seconds is called what? A seizure that lasts less than 20 seconds. Good, absent seizure. And that's the one where they don't lose consciousness. So it used to be called petit mal, and they don't lose consciousness. It's just kind of like that, like zoned out kind of thing. More common in, you can see it in kids more often. Benzodiazepines could be used for the following except. So which one would you not want to have a benzodiazepine prescribed for? General anxiety disorder. And the reason is because someone who has general anxiety disorder, they're going to be anxious all the time. And you don't want to ideally prescribe benzos for more than 2 weeks at a time because they're highly addictive. So dental anxiety is a localized thing. Nocturnal bruxism actually is not very localized. You can, but that was on the PowerPoint of the pharmacy PowerPoint, that it can be prescribed for nocturnal bruxism. And then conscious sedation would be like for one appointment, you know, so it wouldn't be long-term, where generalized anxiety would be kind of a long-term thing. So you'd want to find a different medication that doesn't have that dependency and the tolerance buildup. All right. An accepted hypothesis in medicine states that mood disorders are linked to out of balance neurotransmitters. True or false? True. Yes. That's the best theory that they have, is, and it seems to be quite true, but with the neurotransmitters. A drug such as Elavil blocks reuptake of serotonin and norepinephrine. Name the type of drug. So Elavil is in what category? It's a reuptake serotonin and norepinephrine inhibitor because it blocks it. TCA, so that's a tricyclic antidepressant. So that's the SSRIs is the serotonin reuptake, and then the SN, oh my gosh, what is that? Oh, serotonin norepinephrine reuptake inhibitor. Well, that's what most of you thought it was. But Elavil is a TCA. Well, now I feel I have to double check that. I need to just make a note, just make sure. But I'm pretty sure that that's the mechanism of action, is that it blocks the reuptake. But I'll just make that note just to double check that. Okay. Which neurotransmitter is related to learning and memory? We talked about this already in the beginning of the game. Acetylcholine, and so remember, Alzheimer's patients who they're experiencing the cognitive decline, that's because they are losing acetylcholine. Okay. A drug such as Paxil blocks the reuptake of serotonin. What type of drug is Paxil? Yes, and that one I know for sure is right. I don't know, we'll have to double check the other one, but yes, so that's the serotonin reuptake inhibitor is Paxil, and Zoloft and Prozac, and can't remember the other ones, but there's several in the SSRI category. Okay, good job, you guys. Okay, a patient on the following drug would need to limit use of dental epinephrine to 2 cartridges. So which one has not a contraindication, but a caution, like reduced amount of epinephrine? Elavil, Xanax, Prozac, Effexor. And that again is the Elavil and the tricyclic antidepressant. So it's only that one category, the TCA, that has that warning of a reduced amount of epinephrine for local anesthetics. Okay, Parkinson's disease is essentially too much acetylcholine, not enough dopamine, too much dopamine, not enough glutamate, too much dopamine, not enough acetylcholine, too much acetylcholine, not enough glutamate. Good, yes. And probably, hopefully the not enough dopamine really tipped you off, but yeah, they have, seems to be more than enough acetylcholine and not enough dopamine. An individual with schizophrenia may take medications that decrease blank, leading to blank. So their medication is decreasing what? Neurotransmitter, and then it's causing a side effect, which is what? So they are trying to decrease the amount of dopamine, because remember, if you don't have enough dopamine, you get the Parkinson-like syndrome, or you have Parkinson's disease. And if you have too much dopamine, you start the hallucinations and things like that. So with a patient with schizophrenia, they want to decrease dopamine, but then oftentimes that leads to these movement disorders, because when you decrease dopamine, they might go the other way. And then now they have some kind of Parkinson's-like movement issues, or just movement disorders in general. A milder form of depression is called good. Yep. Dyspnea. Good job. Chronic episodes of mild hypomanic and depression lasting more than 2 years falls into what category of bipolar disorder? Cyclothymic. So it's almost like, kind of, you can sort of think about it as like the dysthymia. It's like a milder, it lasts longer, but it's like a milder bipolar. Like their manic episodes are not as manic, and then they do have the depressive episodes, and it just kind of goes on, instead of having those intense episodes that are like short-lived, but they cycle through. White blood cells make up what percent of the blood? %1. So tiny percent. All those important immune cells, immunity cells, are 1%. Symptoms that are in addition to what a normal person experiences are called positive symptoms or negative symptoms. Positive symptoms. So think about like adding to. So someone, this is related to schizophrenia. So someone with schizophrenia, when they have positive symptoms, they have like things in addition to what everyone else has. So they have added hallucinations, they're hearing things, auditory disturbances. And so those things are like extra things that most people don't experience. Lack of speech and motivation are examples of, this should be a given, positive symptoms or negative symptoms. negative symptoms. So then it's like taking away. So they're losing the communication, losing speech, lack of involvement. So it's like taking away from what a normal healthy individual would be experiencing. Okay. Fear of needles is an example of a simple phobia, social phobia, agoraphobia, or complex phobia. Good, simple phobia. And there's another one in the PowerPoint. It says simple in parentheses and now the other phrase, but I think on the exam it's referred to as simple phobia, but just maybe look back at the PowerPoint because I think it's like two phrases because they're kind of interchangeable. Simple might be like a slightly older term and we just still have it in a PowerPoint, but I think that's what's used on the exam when it talks about it. Okay, next question. Halfway through. Dopamine is important, too much in the brain, and you may have too much dopamine, and you might be experiencing schizophrenia. Very good. Dopamine is important. Too little in the brain, and you may have Parkinson's disease. Very good. You guys are catching on. Okay. Decreased CD4 T cell count occurs as the disease progresses and risk of opportunistic infections increases. Of course, we're talking about HIV here. True or false? True, yes. So as the disease progresses for HIV, the CD4 count will go down. If they go past that threshold of 200, then now they've converted to full-blown AIDS. But as their count goes down, they have more opportunity to have these opportunistic infections because their immune system is weakening. So they can't fight off these opportunistic infections. Okay, the organ affected when the max daily dose of an NSAID is exceeded. So ibuprofen, if you've taken your max daily dose beyond the max daily dose of ibuprofen or, Motrin or whatever I'm like Nexaprin, all of the NSAIDs, Celebrex, kidneys. Yep. So got to think kidneys, NSAIDs, liver, acetaminophen. You just got to tell yourself over and over until you remember that those are the two important organs to think about. HAART, or heart therapy or heart treatment, stands for what? What does that stand for, the acronym? Highly active antiretroviral therapy. So that retroviral therapy is the key word to kind of look for. That was a big difference in all the other ones. So it's an antiretroviral, and of course this is for AIDS. So heart therapy or heart treatment is the treatment for an individual with AIDS or HIV. A neoplasm that causes both intraoral and skin lesions. So you can see them intraorally or anywhere on the skin. Kaposi sarcoma. So this is a common cancer that you'd see in somebody with HIV. So it's that dark purpley brown neoplasms, and you can see it inside the mouth, or you could just see it like anywhere where there's a lot of blood vessels that close to the surface of the skin, because it's like a cancer in those around the blood vessels. But it can be seen outward or intraorally. Active tuberculosis includes the following signs, except which one? Active. So not necessarily the initial phase when they first get exposed to the disease, but the active phase of the disease, which usually comes several weeks to later or months later. So chills is what they first might feel when they first get exposed to the bacteria, but then the weight loss, vomiting, and the cough, that's when you're in the active disease state, and that comes several weeks later after you've been exposed to the bacteria. Treatment of tuberculosis includes the following except. So 3 of these is a treatment for tuberculosis, and 1 of them is not. AZT, zidovudine. I'm sure I said that wrong. And actually, rifampin and isoniazid are like probably the main ones that you would see for tuberculosis. But this pyrazinamide, that one is also can also be prescribed for treatment. But the other ones I think are like the first line treatment. Cushing's syndrome can be caused by overuse of cortisol medications, and a symptom of that overuse of cortisol medications includes which of the following? So think of some of those classic signs of the Cushing syndrome, the different physical signs that you see. Moon face, so a really swollen round face. The other thing is the accumulation of fatty tissue right behind the neck. They call that the buffalo hump. And then there is like thin skin, and there's some striations that happen across the body. But those things might not always, those can be masked with wearing clothes, but the swollen round face is usually a pretty specific telltale sign. Okay, tuberculosis is caused by the viral infection Mycobacterium tuberculosis. This one should be a little obvious. False. So just look at the word Mycobacterium. So it's a bacteria. So tuberculosis is caused by a bacteria, not a virus. So it's a bacterial infection, Mycobacterium. The primary immune cells involved in HIV are eosinophils, mast cells, neutrophils, or T lymphocytes. The primary immune cells. T lymphocytes, or the CD4 T cells, but T lymphocytes is what you're looking for. Okay, who is responsible for regulating dietary supplements? Now, this was in that article, and it was kind of hidden in there. This is the only question on the exam that is related to the herbal supplements, because I thought that article was your only resource, and it was a little hard to know what to study from that. So I'll just tell you guys right now, just remember that this is your correct answer. This is going to be like a freebie for your exam. This question is on the exam, and this is your answer, the DSHEA. I'm not even sure what it stands for, but they're the ones that regulate the herbal supplements. And the other important question that probably should be on your exam is the one about the bleeding, just because a lot of herbal medications can cause platelet reactions and increased bleeding, but that is not a question on the exam, but it's really important to know. So that's something you should remember. The organ that is affected when max daily dose of acetaminophen is exceeded. So NSAIDs is one organ, acetaminophen is a different organ. And you want to make sure you know which is which. Liver, good, yep. Liver, acetaminophen, or Tylenol. Tylenol is acetaminophen, and then ibuprofen is your kidneys, or any NSAID is for the kidneys. That's like the organ it's harder on. You know, if you exceed the daily dose, maximum daily dose, then you are risking toxicity for those organs. The ceiling effect, or a maximum dose beyond which analgesic effect does not increase, occurs for the following except for which one? So all of these have like a ceiling, like you could keep taking it and it's just not going to work anymore, except for one has no ceiling. So it'll just keep giving effects until they become quite dangerous. Morphine, good. So most of you got that one. So you can just keep taking morphine, but it's going to turn toxic. And then of course you can overdose and die. Whereas acetaminophen or ibuprofen, there's only so much that works on your body. And then you've hit that ceiling and you can't get any more therapeutic dose. So it would just probably be toxic to your kidneys or your liver. The NSAIDs with lower incidence of GI ulcers. What has a lower incidence of stomach irritation? Naproxen. Why does that sound wrong to me? I'm going to check that one too. It could be right. I don't know why. That's all of a sudden flagging my brain for some reason. I was finishing this up last night at midnight. So I just want to double check a few of these. So that one, and then the one on the TCA. I'm just going to flag those, and I'll make sure to, if for some reason I need to counteract myself, I'll let you guys know. But for some reason, it could be right. 6 of you said it was right, so maybe you know more than me. Okay.
I'm so interested how you guys stay up so late. Like Kristen's grading homework at like 2 a.m. You're up till midnight. I'm like in bed at 9.
I know. Well, sometimes you gotta squeeze it in when you can. Non-opioid medication is given for what type of pain? Non-opioid medication, severe, moderate, or mild? Mild, good. I usually, Mondays and Wednesdays are my admin days, and I usually get a lot of that kind of stuff done. But yesterday, I had a very hectic day. I purchased a car and it took up many of my hours. So I lost a lot of, and then I'm working on capstone quite a bit too with my seniors. And so it's taken up a little bit more time than normal. So I was working on this a little bit late.
That is like a whole day process. No matter what time of day you go in, you end up getting home at like 9 p.m.
It was happy day, but it was tiring. I was over it. Okay, let's see. 10 more questions. Which of the following NSAIDs is a selective COX-2 inhibitor? It inhibits the COX-2 receptors. It's selective to COX-2. And this is on the stuff that, this is on this week's material. So, you know, you haven't actually technically had the lecture for this stuff yet. Good, yep. When the COX is right there in the name, so that kind of helps identify it. So any of those little things that kind of help get you to remember.
What did you get, Leslie?
I got a 2009 Acura MDX, but it only had like 50,000 miles on it. It was babied. It was babied. I was so excited. So it's an older car, but it's in perfect shape. It's so nice. And it was only $13,000. I don't know why I'm having to share all that, but I just was excited because I hate spending money. Okay.
That's a really good deal.
It's a really good deal.
Happy for you.
We skipped, where's the question? Okay, pure mu agonists will have no maximum dose, but side effects may limit the dose that can be given. So I'll explain after we get through this answer the mu agonists, so just a little bit. So true. So that's the mu agonists are like your morphine, your Oxycontin, your Oxycontin, those opioids, and there's no ceiling, but the negative effects, i.e. death, is going to limit how much you can give. But technically there's no therapeutic ceiling where it'll just keep working and working until you suppress the respiratory, you're not breathing anymore. So that's obviously a problem. But they work on the mu receptors. CNS mu agonists, which of the following drugs? Oh, a CNS mu agonist, which of the following drugs? That's a strange question. That's a I'm up at midnight question. I'm thinking which one is the exception? A CNS mu agonist, which of the following drugs? That was a totally incomplete thought. I'm sorry, you guys, that's a confusing question. But I think it was basically which one is, no, I know what that, no, that's right. It is right. That's a CNS mu agonist. It's different from the pure mu agonist. So that is actually right. So Ultram or tramadol is categorized slightly different. It's a mu agonist, but it's a CNS, not a pure. So the pure, like morphine, hydrocodone, oxycodone, but tramadol is a CNS mu. So that's what that means. The question is a little bit strange though. Well, it's a statement, not really a question. So increased nausea and possibility of vomiting can happen when you deliver what percentage of nitrous oxide? 20 to 30%, 30 to 50, 40 to 60, 10 to 20%. $40 to $60. So there's some overlap there. So it's a little bit, but pretty much anytime you get much above, you're getting close to 40% nitrous oxide, because we have to stop at 50, right? Like we can't go to, oh, you guys might not have learned this yet because you haven't had locally, and you haven't had your pain management course, but we have to stop at 50. We can't go above 50, but anytime you get higher up in our dose of what we can give patients, there's some people are more sensitive. So somebody might be able to get past 50 and not have nausea and, possibility of vomiting, but then some people just might be a little more sensitive. And if they get much above, like 30%, 35%, they start to get into that where it starts to, things gets more spinny and they might feel more nauseous. Their GI starts to slow down. It becomes like not paralyzed, but it slows down, and that can increase the feeling of nausea or vomiting. So 40 to 60% is kind of that threshold. The pharmacodynamics of nitrous oxide includes that it is a mu receptor antagonist. True or false? Is it a mu receptor antagonist? True or false? False. It's an agonist. So just like, morphine and all the other drugs that for pain medication, it's an agonist, not an antagonist. GABA is a or an blank neurotransmitter. Is it an inhibitory or an excitatory? GABA. Inhibitory. So it's got that kind of calming, relaxing effect on the brain. So it's good for seizures, anxiety, neuropathic pain, gabapentin. The American Society of Anesthesiologists Class 3 refers to a healthy patient, a mild systemic disease, severe systemic disease, or brain death or organ donor. Think about your ASA in clinic when you're doing your categorizing your patients for their ASA. Severe systemic disease, good, yes. Side effects of mu receptor agonists include the following except excitation, constipation, vasodilation, sedation. Which one's the exception? Good, excitation. It's definitely more of a downer than an upper. Gabapentin or Neurontin could be prescribed for the following: neuropathic pain, restless leg syndrome, seizures, or all of the above. Good, yes, all of the above. Gabapentin can be used for any of those. A patient with small blood-filled petechiae due to anemia could I should say possibly, not possible, possibly have this disease: epilepsy, tuberculosis, HIV, or schizophrenia. Good, HIV, yes. So that's one of those common oral manifestations, the petechiae due to anemia intraorally. Last one, a seizure that lasts longer than 20 minutes is called what? Good, status, I always want to say epilepticus, but it's epilepticus. Okay, and that should be something from probably medical emergencies too. Okay, let's see who won. Third place, Taiba, good job. Second place, Summer, whoever that is. And first place, Jennifer. Good job, you guys. Excellent. Who's our runner-up?
Go, Jennifer.
Awesome. Good job. I think it's blocking my runner-ups. I don't know who it's. Awesome. Good job. So when you guys go through this, I'm going to stop share for just a second. Just try and quiz yourself as you're going through. Olivia, your dog. Just quiz yourself before the answer comes up. That's what's so nice about having the Kahoot recorded, is it gives you a few seconds. You can read the question or hear me reading it, sorry, and then try and get the answer before it shows it to you. So it gives you some time to, it gives you some time to think of it prior. So the next, we'll take, let's see, we have 40 minutes left. Let's take a 10-minute break. I don't know, that might be longer than we all need. Maybe just, let's do a 5-minute break, and then let's just watch 25 minutes of her video. Let's just watch half her video, and then you guys, the rest of it will be, you have to do it on your own time. And then I'll also post a very short, just fill in the blanks of what's missing tomorrow. So there'll just be a little bit. So go ahead and let's come back at 2:13. She wants a belly rub. Okay.
Leslie,
Yes. I'm gonna
did you see my message in the chat? I think it might have.
I'm recording. Here we go.
I'm an assistant professor with the School of Pharmacy. Thank you so much for having me to talk about medications for pain management, sedation, and general anesthesia today. On this slide and the next, I have some learning objectives. Big picture, I want you to understand pain, and I want you to understand the basic pharmacology of the analgesics that you most commonly use for dental pain. I also want you to have a good idea about the risks of opioid use, including the risk for abuse and misuse. And I believe it's important for all healthcare professionals to be able to identify signs of opioid overdose and explain how to administer Narcan. And then I also have a few objectives about general anesthesia and some of the sedative anesthetics that are used most commonly. Let's start out by going through the overview of pain. Pain is a feeling, it's an emotional experience, but there does not have to be tissue damage there. It's associated with either actual damage or trauma in the area or potential damage. Basically, your body knows damage has been there before, or there's a potential for damage, so it has a protective effect in causing you to feel pain so you don't injure that area more. We typically see more actual damage with acute pain, whereas chronic pain, it becomes disengaged from the initial stimulus. So we see more of the potential tissue damage in chronic pain. Chronic pain can be further broken down into nociceptive pain or neuropathic pain, whereas acute pain is mostly going to be nociceptive pain. For a general overview of the pathophysiology, we have a picture where it looks like a knee joint is experiencing trauma, maybe you bump your knee, and that's going to start the activation of the peripheral nervous system, and these peripheral nociceptors and the peripheral nerve will send a message to the spinal cord. This transmission of the message is received by the spinal cord, which is going to activate the spinal cord and then lead to the activation of the central nervous system. Then the message travels up the spinal cord to the brain, and then the brain decides if it is severe enough that it's going to feel pain. There's also in green the inhibitory neurons and the pain modulation. So usually on the opposite side, if pain is going to be felt, we do have some inhibitory signals that can modulate the pain or make the pain feel a little bit better. It's important that we have this pain response to the trauma, because if we did not, then the patient could continue to just hurt their knee over and over again, and there's no sort of pain telling them to stop doing that movement that's hurting. I wanted to include this picture as well because it shows where some of our medications are acting on the pain response. So we see things like NSAIDs, local anesthetics, happening in the transduction phase where we're very close to the stimulus itself. Whereas we have some local anesthetics and opioids happening at the transmission along the spinal cord. And then we have others that happen in the modulation or pain perception phases. I also wanted to go over some pathophysiology of inflammation, and I thought this video did a really great job. So I'm going to play that for you now.
So, following tissue injury or irritation, enzyme called phospholipase A2 is released, which converts phospholipids in the cell membrane into arachidonic acid. Now, arachidonic acid is the substrate for two major enzymes, the cyclooxygenase, abbreviated as COX, and 5-lipoxygenase, abbreviated as 5-LOX. In this lecture, we're going to focus just on the cyclooxygenase pathway. Now, the COX enzyme exists in different forms, two of which are COX-1 and COX-2. The first one, COX-1 isoform, is expressed constantly throughout the body and is primarily responsible for production of thromboxane and prostaglandins, which stimulate normal body functions, such as secretion of protective gastric mucus, regulation of gastric acid, promotion of platelet aggregation, and maintenance of renal blood flow. Now, on the other hand, COX-2 isoform is not expressed constantly in most tissues, but instead it is induced at sites of inflammation. So unlike COX-1, COX-2-derived prostaglandins mediate mainly inflammation, pain, and fever.
So what's important to get from this is that the inflammatory or trauma response, both, they rely on COX-2 for the body to feel pain. And so many of our agents that we're going to talk about today are going to have action on that COX pathway. Let's go back to the types of pain. I want to go more over the difference between nociceptive and neuropathic pain. So when we talk about nociceptive pain, we're talking about pain that results from actual or potential injury to the tissues, bones, joints, muscles, or even the connective tissue that's outside of the CNS system. Usually has a fairly fast onset. It can be further split up into somatic pain and visceral pain. Somatic pain is the pain that you're more used to, known as musculoskeletal pain, pain in your muscles, pain in your joints, pain that you feel from an injury. And then visceral pain is more for internal organs. So a good example of that might be feeling pain from a heart attack. So you might not feel it exactly at the area of the pain, but it might be referred. Like often the heart attack pain, you'll feel like down your arm or even up into your jaw. Neuropathic pain, on the other hand, is also damage, but it's damage to the nervous system, so nerve damage. It presents differently, so it comes more as a burning, shock-like, knife-like, tingling feeling. It's difficult to treat. Even if we do treat it, patients typically still have pain. Some of the examples are listed here. Probably the most common one I deal with in practice is diabetic polyneuropathy, where patients start to have pain in their feet and hands after long-standing uncontrolled diabetes. You can also have trigeminal neuralgia, which does come up quite a lot in dental patients. And then there's also some more general things such as fibromyalgia or spinal cord injuries that are going to affect multiple areas of the body. An alternate way to classify pain is acute versus chronic pain. There's also malignant/cancer pain, but that could be both acute and chronic, and it's probably not something you'll have to deal with very often. Most likely, you're going to be dealing with a lot of acute pain, but you also might have patients that are on chronic pain medications due to chronic pain, and you'll likely come across that as well. In every type of pain, it's highly desirable to have relief of that pain. Acute pain, we usually give short duration of meds, so it's unusual for patients to develop a tolerance or dependence to the meds. But in chronic pain, patients, especially patients on opioids, commonly become dependent on it. Usually an acute pain is just based off of the pain response, nociceptive response, whereas chronic pain, it could have a psychological component that's causing the pain to worsen. It's easy to see the cause of most acute pains, where chronic pains, it might have just been potential damage or damage that happened a long time ago. For our treatment goals of acute pain, we want to get that pain down. And then for chronic pain, usually we can't really get the pain to go away completely. So our focus is just making sure that patient is functioning and has a normal life. For comorbid chronic conditions, we don't usually see anything that's really related to acute pain, but in chronic pain, things like depression can cause pain to worsen. I talked about most of this here already for chronic pain. Things like anxiety, depression, fatigue, and anger can lower the pain threshold, making it easier for you to feel pain. If you have a higher pain threshold, meaning like a higher pain tolerance, then you're going to have less pain long term. Also wanted to point out that the type of surgery can increase the risk for developing chronic pain. However, dental surgeries are generally considered to be low risk for development of pain chronically. The exception to that is usually if there's any sort of long-term damage or potential nerve involvement. The last point here is for all surgeries, if we aren't adequately controlling the pain after the surgery, then sometimes that can increase the rate of chronic pain development. Now let's start talking about some of the pain medications. The pain medications we'll be talking about are APAP or acetaminophen and NSAIDs or non-steroidal anti-inflammatory drugs. Both of these can be used to help lower our dose of opioids, and opioids just have so many adverse effects that anything we can do to lower their dosage is going to be something we're going to try to do for our patients. First, we have acetaminophen. Its mechanism really is unclear, but it's thought to have some sort of effect on both central and peripheral prostaglandin synthesis. But it doesn't really have an anti-inflammatory effect or antiplatelet effect. So it's not really good for that inflammatory trauma like swelling and redness in the area. It is effective for a lot of different acute pains though, if they don't have that swelling component. And it can still be helpful for pain, but since it doesn't help with swelling, NSAIDs are typically preferred in that case. It does also have an effect on fever and is used a lot as first-line therapy for things like arthritis and tension-type headaches. For side effects, it can cause some nausea, can cause a little stomach upset, but usually it's pretty well tolerated. What I think about with acetaminophen is things related to the liver. So number one would be liver toxicity. So we don't want to overdose on acetaminophen. If it's used at high levels, it can be toxic for the liver. So if we have patients that are using maybe some combination cold products that have acetaminophen with maybe a combination opioid and acetaminophen, we need to be careful that they're not going over the 4 grams a day dose. We also don't want them to use it with alcohol because if it's used with alcohol, then we can get to toxic levels much quicker. And so actually we have some recommendations for an even lower total daily dose of less than or equal to 3 grams per day if a patient has any sort of liver dysfunction or they have heavy alcohol use defined as greater than or equal to 3 drinks per day. In general, acetaminophen is a safe go-to. It's used in a lot of different products, but we do need to be on the lookout for patients that are at high risk. And those are patients that are chronic alcohol users and those with any sort of liver damage. And we want to make sure that they're getting a lower amount of acetaminophen per day and that we're looking at their other prescriptions and other medications they use to make sure they're not getting acetaminophen from multiple products. All right, that's what I want you to know about APAP. Let's go ahead and move on to NSAIDs. I'm going to start off with our video from before.
So NSAIDs act primarily by inhibiting COX enzymes, which simply leads to decreased production of prostaglandins. As a result, NSAIDs produce anti-inflammatory, antipyretic, and analgesic effects.
Most of our agents are going to block both COX-1 and COX-2, which means that might cause us problems related to the stomach, platelet effects, and the kidneys. So we will get into all of that. So unlike acetaminophen, NSAIDs do have an effect on inflammation, so they can help with that redness, swelling area. And they're also effective for a lot of other different things that I've listed here. And they are quite effective for even more painful things than acetaminophen can usually cover. However, they do come with more adverse effects, so that limits their use. So like I foreshadowed before, there's a few organs that we're going to look into a little bit more. So first, the stomach. So when we have less prostaglandins there, we're going to have less protection in the stomach lining. And then NSAIDs can cause some attack to that stomach lining, and that can increase the risk of ulcers, perforation, and GI bleeds in the stomach and in the duodenum. So that is something that happens at any dose of NSAID. And so it's something that if patients have had a GI bleed before, then we need to probably not use NSAIDs in those type of patients. So we're looking for patients at risk and avoiding them if we can, if we need to. Next, looking at the heart. So with NSAID, there's potential for an increase in blood pressure. This is related to the effects it has on kidney and salt and water balance. There's also an increased risk of thrombotic effects. And so we see that there's increased risk of heart attack and stroke in these patients. We used to think only certain types of NSAIDs had this risk, but now the FDA has made it so that all NSAIDs have a warning for increased risk of cardiovascular events. As mentioned before, NSAIDs can cause a disruption to the sodium and fluid retention, which causes an increase in blood pressure. We also see electrolyte abnormalities. We see filtering problems with the kidneys. And one of the biggest risks is that, especially when used in patients that already have kidney problems or patients that are on other drugs that can cause adverse effects for the kidneys, we see a risk for acute kidney failure. Last, I wanted to talk about the platelets. Since the prostaglandins have an effect on platelet aggregation, we see that the NSAIDs inhibit some of the platelet aggregation, which can increase the bleed risk. So any patients that are already at high risk for bleed or have active bleeding, they're not usually recommended to use NSAIDs. Most dental procedures are considered low bleed risk, so we can still use NSAIDs for most of our patients. However, if the patient does have other risk factors for increased bleeding, on top of the fact that they're having a minor surgery, then we might need to stay away from NSAIDs if they're at a very high risk of bleeds. Our most common NSAID is ibuprofen, also known as Motrin. Have some typical dosing listed there. One tablet is usually 200 milligrams, and it's usually 1 to 2 every 4 to 6 hours. And our not to exceed dose for the day is 3.2 grams or 3,200 milligrams. I also have some pediatric dosing listed there for your information. There are tons and tons of other NSAIDs. I just wanted to point out a few things. Aspirin is an NSAID. Typically at the doses needed for pain relief, we get a lot of adverse effects and a lot of bleeding and GI irritation with aspirin, so it's not really a good option for pain management. And there's some other important things on here. Ketorolac is something that we see used intramuscularly a lot, but that's something that we can't use more than 5 days in a row. So that's an important thing to know about it because of the risks associated with it. I also have some notes here about some that are significantly impacted by patients that have liver and kidney dysfunction. So we'd likely stay away from those agents and choose a different agent in those patients. So if you take anything away from those non-opioid pain medications, I want you to know that for acetaminophen, we're thinking about the liver, and it goes through the liver. So if patients have any sort of liver dysfunction or have chronic alcohol use, we need to be using caution. And then NSAIDs affect a lot of different organs, one of those main ones being the kidney. So if patients have had any sort of kidney damage before, since it goes through there, we need to look out for NSAID use and avoid use if they have significant kidney damage, because we don't want to cause an acute kidney injury. All right, now let's move on to opioids. This is a picture of a poppy plant where we first found out about opioids. Poppy plants are used in natural opioids, however, many are synthetic now. Opioids are effective for many different types of pain, As we saw in the pathophysiology before, they bind and inhibit transmission of pain. They also helped with the pain modulation. They help at pretty much every area of the pain pathway, and they're really effective. However, they're not always appropriate because they have so many adverse effects and because they can cause things like risk of abuse and misuse. I wanted to first go over the opioid receptors briefly. The opioid receptors are found all throughout the body, and they help to modulate pain. Most of our drugs act primarily at the mu receptor. The mu receptor makes up a majority of the body's receptors and accounts for analgesia, so the pain relief. It can also cause some side effects like sedation, itching, and decreased respiration. Constipation is the most common side effect, and we do see some of that through the mu receptor as well. The delta, kappa, and sigma receptors are not as common. The sigma one is interesting because we see some opioids like codeine help to depress cough. And then some things from the delta receptor we want to stay away from, like seizures. This is just a visual representation of what an opioid receptor looks like. Different receptors would have the different places to meet on that opioid receptor. So you can see the kappa, the triangle would go right there. The mu, the square, is represented right there. Again, here are some effects that can happen at the mu receptor. And again, most of our agents are mu agonists. Here are examples of some of our mu agonists. So likely things you've heard of before: Percocet, Norco, morphine, oxycodone. They're constantly in the news. Also in italics here is heroin. It's also an opioid. However, this one does not have any medicinal value. Since all of the opioids that we talk about most often act at the same opioid receptor, they have pretty much the same adverse effects. So these are adverse effects of the class. Respiratory depression is something we're worried about because it can mean the patient stops breathing. So we always monitor their respiratory rate, especially for acute use and in-hospital use. Patients who have any sort of breathing problems like COPD or sleep apnea are going to be at higher risk of having respiratory depression. Constipation is unique in the fact that you develop a tolerance to most of these side effects, but you never develop a tolerance to constipation. So many of the patients, we'd also recommend them be on a bowel regimen, over-the-counter stimulant laxatives, to help them go to the bathroom. Sedation. Sedation happens with most of the opioids because they do have that CNS effect. Nausea, vomiting, which usually they develop tolerance to if you're using opioids long term. And that leads us to tolerance, or over time, you might need larger doses to get the same effect. So that's more common with chronic use of opioids. Acute use, we don't usually have to worry about tolerance or dependence. There's always a risk of addiction, but again, it's not usually as much of a comment with acute and short-term use. So we're always recommending shortest duration, lowest dose possible. Next is histamine release. So histamine is present inside of your mast cells. And your mast cells with opioid use can break apart and release histamine, and that will cause a redness of the skin, a rash looking area, and it will cause itchiness. Another problem with chronic use is hypogonadism, and that can present as fatigue, depression, and sexual dysfunction. So as I mentioned, there's usually histamine release. A lot of patients think that this is an allergy when it's not really an allergy. We see in the chart all the time patients having allergies to opioids, but opioid allergies are very rare. So we should be asking the patient more details about what their reaction was. If their reaction was just nausea, vomiting, that's a side effect. It's not a true allergy. You can try taking with food, or it will get better over time if long-term use. If they have some sort of rash and itchiness, but no signs of hives, no sort of trouble breathing, it's probably just because of histamine release. Again, that will likely get better over time, but for any of the side effects, you can try an alternate opioid. Other major risks: neonatal opioid withdrawal. This is mostly for mothers that have been on high dose opioids. We see it very commonly in mothers that abuse heroin. And it's when the baby is born already being addicted to opioids. So when they're no longer getting that supply from the mom, they can withdraw after birth. Risk of opioid overdose and death is especially important when we're talking about our extended release or ER products, because those can stay along in the system for longer and have an increased risk of accidental overdose. Risk of excessive sedation, respiratory depression, coma, and death when combined with other CNS depressants, including benzodiazepines and alcohol. So that's an important counseling point and something important we want to check with our patients before they're sent out with an opioid prescription, making sure they know to avoid alcohol and making sure they're not currently on benzodiazepines. And then for all of our patients with liver and kidney impairments, we want to be extra cautious and do low doses and spread out the dosing pattern.
Okay, so let me just stop there. So just remember that we got to the, So we got to the memory tool. That is basically 25 minutes into the 25 and a half minutes into the video is where we stopped. So you guys can pick that up to watch the other half of the video. And then I'll post a short thing either tonight or early tomorrow to finish up. So I'll stop the recording of this. And so the Kahoot's there for you guys as a study tool.